Okay, today we will be speaking of coronal polish, and we will, as always, pronounce, define, and spell the key terms, discuss coronal polishing, the difference between a prophylaxis and coronal polishing, the indications and contraindications, principle of selective polishing. We'll also be talking about extrinsic and intrinsic stains and methods used to remove plaque and stains, hand pieces, attachments, the importance of selecting an appropriate polishing agent, and aesthetic restorations. Coronal polishing. It is a technique used to remove plaque and stains from the coronal surfaces of the teeth. Polishing the crowns of the teeth is considered mainly cosmetic, but there are instances in which coronal polishing has therapeutic value as well. In some states, coronal polishing is delegated to registered or expanded function dental assistants who have had special training in this procedure. So in this state, Florida, we are allowed to do coronal polishing. Uh, an oral prophylaxis, commonly known as prophy or cleaning, is the complete removal of calculus, debris, stain, and plaque from the teeth. Again, we do coronal polishing, and the hygienist does the removal of the calculus, and we'll go more into that. So here is some of the things that you will need for coronal polishing. If you look at letter A, this is a bristle brush, okay, and it gets attached to this Prophy Angle. B is a rubber polishing cup. C is the reusable Prophy Angle. Anything in stainless steel, metal, okay, it gets autoclave. Anything that is plastic, like this disposable Prophy Angle, gets thrown away. Most the time, most offices are using letter D to do the cleaning, polishing, coronal polishing. Selective polishing is a procedure in which only those teeth or surfaces with stain are polished. The purpose of selective polishing is to avoid removing even small amounts of surface enamel. In some individuals, stain removal may cause dental hypersensitivity during and after the appointment. Coronal polishing and fluoride application. So historically, teeth were polished to remove all soft deposits and stains before the application of fluoride because it was believed that there would be greater uptake of the fluoride into the enamel. As scientific knowledge has evolved, it has been shown that polishing does not improve the uptake of professionally applied fluoride. Now, the benefits of coronal polishing. Polishing prepares the teeth for the placement of dental sealants. Smooth tooth surfaces are easier for the patient to keep clean. The formation of new deposits is slowed. Patient appreciates the smooth feeling and clean appearance. Polishing prepares the teeth for the placement of orthodontic brackets and bands. I will tell you this though, if you do polish the teeth for sealants, you must use pumice, okay? Because if you use the one with the fluoride, which is usually the paste that we use to polish the teeth, the sealant does not stay on. So pumice is what we use. Dental stains are primarily an aesthetic problem. Some type of stains can be removed and others cannot, so it's important for you as a dental assistant to correctly identify stains. There are other treatment options for patients with stains that cannot be removed, include professional and at-home bleaching procedures, enamel microabrasion, and cosmetic restorative procedures, such as laminate veneers and composite restorations. So there's two types of things that we're going to talk about, and one is endo and one is exo. One means inside the tooth and one means outside of the tooth, and we'll go into that in a few seconds. So again, endogenous stains originate within the tooth as a result of development and systemic disturbances. So inside, endo means inside, exo, okay, outside the tooth. Usually this is responsive to environmental agents, such as like tobacco, um, coffee stains, tea stains, okay? So those are your exo, all right? So again, endo is in, exo is out. Let me show you a picture. So endo, this is inside these things, inside, okay? So what this is showing is tetracycline. So it could have been when the baby was in the mom's womb, the mom could have taken tetracycline and it passed down to the child. And when the child started developing their teeth, they have these things. This is inside, they cannot be removed. Okay, the only way you can hide those things is if you put a crown on top of the teeth. Here's some more examples of endo. Again, endo is inside. Enamel hypoplasia, okay? This is basically pitting or grooving. It's these like here, I don't know if you can really see it well, but it's over here, all right? So it looks like the enamel is basically wearing away. Those things cannot be removed. They can be fixed, but not removed. Here's some more. This has to do with dental fluorosis, too much fluoride, okay? And again, you cannot remove this. You can only hide it with crowns or veneers. Um, Here is another example, okay? So again, secondary caries. So if the person had caries, they removed the caries, but they left a stain. So that's what they're showing here. Exo, now exo is outside. So exo, that's like your amalgam restorations, okay? Coffee stains, tobacco stains, things like that. Let's see if I have any more examples here. So methods of removing plaque and stain. We have what's called air polishing, and it involves the use of a specially designed handpiece with a nozzle that delivers a high pressure stream of warm water and sodium bicarbonate. I don't know too many people are still using the air polishing right now just because it is it goes all over the place, and because of the COVID, everything is being trying to kept to a minimum of spraying outside of the mouth. So I'm not sure if people are still using the air polishing. Rubber cup polishing, this is the most common technique for removing stains and plaque and polishing the teeth. It's rotated slowly and carefully by means of prophylactic angle attached to a slow speed handpiece. So really important, you attach the prophy angle to a slow speed. Polishing cups, soft web polishing cups are used to clean and polish the smooth surfaces of the teeth. The polishing cup is attached to the reusable prophylaxis angle by means of a snap-on or a screw-on attachment, which I showed you earlier in the PowerPoint. Also, I showed you bristle brushes. They could be made of natural or synthetic materials, may be used to remove stains from deep pits and fissures of the enamel surfaces. They can cause severe gingival lacerations and must be used with special care. They're not recommended for use on exposed cementum or dentin because these surfaces are soft and are easily grooved. A lot of people use them also for ortho to get around the brackets. Prophylaxis angle and handpiece, also called a prophy angle, and it attaches to a slow or low speed handpiece. Slow and low is the same thing. The reusable prophy angle must be properly cleaned and sterilized after each use. The only thing about the reusable, don't stick it in the ultrasonic, wipe it down, dry it, bag it, and put it in the autoclave. The disposable is discarded after a single use. The disposable is manufactured with a polishing cup or brush already attached. So there's two different kinds. The handpiece and prophylaxis angle are held in a pen grasp with the handle resting in the V-shape area of the hand between the thumb and index finger. Proper grasp is important because if the grasp is not secure and comfortable, the weight and balance of the handpiece can cause hand and wrist fatigue. So this is the proper way to hold. So pen grasp, like if you're holding a pen with your thumb and index finger, and then you'll probably use your ring or your pinky finger as a fulcrum, a stabilizer. Now, handpiece operation, you have your rheostat, which is the foot pedal. It controls the speed, revolutions per minute of the handpiece. We talked about the handpieces before and the RPMs and how fast they go. The toe is used to activate the rheostat. The sole remains flat on the floor. Apply a steady pressure with the toe on the rheostat to produce a slow, even speed. Use a slow speed handpiece that operates to a maximum of 20,000 RPMs. Release the rheostat to prevent debris from splattering when the handpiece is removed from the tooth for more than a moment. So the rule of thumb is when you're inside the patient's mouth, you step on the rheostat. When you take the prophy angle outside of the mouth, step off the rheostat because you don't want it to spin outside of the patient's mouth. If you do, it's possible that whatever was in their mouth, whether it was the paste, the saliva, starts rotating all over the place. It may even splatter on you, get in your eyes, get the whole entire office or operatory contaminated. The fulcrum and finger rest. The fulcrum provides stability for the operator, must be placed in such a way as to allow for movement of the wrist and forearm. The fulcrum is repositioned throughout the procedure as necessary. The fulcrum may be either intraoral or extraoral depending on a variety of circumstances, such as the presence or absence of teeth, the area of the mouth being polished, and how wide the patient can open his or her mouth. So you should always try to position the fulcrum close to the tooth being worked on, and then kind of move it around as you're moving around in the mouth. Polishing agents, dental abrasives, polishing materials are used to remove stain and to polish natural teeth, prosthetic appliances, restorations, and castings. They are available in extra coarse, medium, fine, and extra fine grits. The coarser the agent, the more abrasive the surface. Even a fine grit agent removes small amounts of the enamel surface. The goal is to always use the abrasive agent that will produce the least amount of abrasion to the tooth surface. So in other words, say somebody comes to you and they have heavy staining. If they have heavy staining, then you're going to use extra coarse. If you look in their mouth and you barely see any staining, then you should use an extra fine. Polishing aesthetic restoration. So many patients have crown and bridge restorations and are having cosmetic resin, composite bonding, and veneers placed to enhance smiles. Improper oral care can quickly damage many of these types of restorations. Coarse polishing paste, use of acid phosphate fluorides, and even hard brushing with abrasive toothpaste can be destructive to the surfaces of restorative materials. A diamond aluminum oxide or low abrasion toothpaste should be used for these restorations. So again, we have different type of paste for pretty much everything. So we have a paste that looks just like toothpaste, and that would be used for anybody that has any types of crown or bridges. Before polishing, the dental assistant must be able to differentiate between tooth structure and the restorative material by carefully examining the margins and the outline of the tooth surface with an explorer and relying on tactile sensitivity. Tactile is touch. Radiographs and reflection of light with a mouth mirror also can help in identifying the location of a restoration, and a review of the patient's dental record can reveal the location of aesthetic restoration. So of course, look in the mouth first before you start, okay, and you'll be able to know. Now, sometimes certain restorations are hard to know if they've had it or not. X-rays usually can tell you. So they're trying to show you that these teeth over here had some type of restoration on it. Usually when it's this light, it's composite, okay? When it's white, it's usually amalgam. Those you can see directly in the mouth anyway when you're cleaning. Also note, this person here has here a little bit of gingival recession, here a lot of gingival recession, because remember, The gum should be right over here at this borderline, and it has receded all this. So even here. So that means that this area right here is exposed. That's the root part of the tooth already, and it can be very sensitive. So you have to be careful. Even on the x-ray, it shows where the bone level is. It should be over here where that faint line is showing the coronal portion. So it should be down here, and it's up here. So again, be careful. Factors that influence the rate of vibration: the more agent used, the greater the degree of vibration, the lighter the pressure, the less abrasion. The slower the rotation of the cup, the less abrasion. So, basically, the harder you do it and the more you do it, the more that you're taking off the tooth. The less that you do it and the less that you use, it's the less that you're hurting the tooth, okay? So we're going to discuss the steps, and they start with the strokes. Fill the polishing cup with the polishing agent and spread it over several teeth in the areas to be polished. You're going to establish a finger rest and place the cup almost in contact with the tooth. The stroke should reach from the gingival third to the incisal third of the tooth. Using the lowest speed, lightly apply the revolving cup to the tooth surface for 1 or 2 seconds. Use light pressure to make the edges of the polishing cup flare slightly, and use a patting, wiping motion and an overlapping stroke. So normally I tell the students that it's like, for the ladies, you should know this, like painting your nails, okay? You start on one end, you go to the middle, you go to the other end. Now, some teeth may need 3 strokes, 4 strokes, 2 strokes, 1 stroke, depending on their size. The other thing that you should know is you should start at the gum line and always work away from the gum. So if this is the lower, you would start at the gum, hit the gum, and then now remember, you're stepping on the rheostat also, so it's revolving. You don't go in circles. It's already going in circles. You're going in one swipe, one, another one, and another one, and you keep on going. Now, here's the cup is flaring a little bit, so you do want it to flare a little bit. Notice how they're starting at the gum and then work their way down. In this case, this is a premolar. The premolar might only need 2 strokes, okay? Here's the mirror for retraction, and here is the finger for your fulcrum. So again, you always want to have a fulcrum, retract the area so you can see better, use some polishing paste, and always gum down or gum up, depending on upper or lower, wherever you're working on. You want to position the patient by adjusting the chair so that the patient is approximately parallel to the floor with the back of the chair raised slightly. Adjust the headrest for patient comfort and operator visibility. For the mandibular arch, position the patient's head with the chin down. When the mouth is open, the lower jaw should be parallel to the floor. For access to the maxillary arch, position the patient's head with the chin up. So, if you're working on the lower, you have their head facing down. And if you're working on the upper, you have their head facing up. It's easier for you to see that way. And again, you keep positioning until you're comfortable. Don't strain your back or your neck, because at the end of the day, you're going to have a back and neck ache. Positioning the operator should keep the feet flat on the floor and thighs parallel to the floor. Operator arms should be at waist level and even with the patient's mouth. When performing a coronal polish procedure, right-handed operators generally begin by being seated in an 8 to 9 o'clock position. And when performing a coronal polish procedure, left-handed operators generally begin by being seated in the 3 to 4 o'clock position. Most of the time, regardless if you're right or left-handed, depending on how the operatory was made, we usually work on the right side of the patient. Okay. Now, there's a picture of the assistant. The assistant is usually the one that does the polishing. Again, if it's a little bit more complicated than polishing, then the hygienist will do the cleaning. Now, full mouth coronal polishing must be performed in a predetermined sequence, so no areas missed. Best sequence is based on operator's preference and the individual needs of patient. Aesthetic and porcelain restoration should be polished first, then the remaining teeth may be polished with the use of appropriate methods for any stain that is present. It reduces possibility that a coarse abrasive will remain in rubber cup when aesthetic restorations are being polished. Position and fulcrums described in the following slides are for a right-handed operator. Now here's your setup, and I will tell you this is the mouth mirror. Here looks like a scaler, saliva ejector. This is the prophy paste and a prophy paste holder. This is disclosing tablets, your floss, your HVE, 2x2 gauze, and this one is your prophy disposable, I'm sorry, not disposable, reusable, and the prophy cup and the prophy brush. If it was plastic, it would be the disposable. Metal is not. Now, to prepare the patient, you're going to check their medical history to see if there's any contraindications to their coronal polishing procedure. Always seat patient and drape with a waterproof napkin. Ask patient to remove any dental prosthetic appliances he or she may be wearing. So if they're wearing a denture or partial, we do have in the office some type of solution to put the denture in and clean those while we're cleaning the patient's teeth. It's sort of almost the same stuff that they use at home or should be using at home. You guys will have to determine once they give you the denture, kind of look at that denture, and if you see that that denture is not clean, you need to educate the patient to make sure that they're cleaning their denture. Cleaning their denture is much easier than cleaning their teeth because they can take the dentures out of their mouth and actually see it in their hand. You're going to also provide patient with protective eyewear, explain the procedure and answer questions, inspect oral cavities for lesions, missing teeth, tori, and so on. And you're going to apply a disclosing agent to identify areas of plaque. So these tablets right here that I mentioned, okay, they come in both tablets and solution. If it's a solution, you're going to need a cotton tip applicator and a dapping dish to put the solution in, and then you put it on. If it is the tablet, you make sure they chew the tablet on both sides, not just on one side, because you'll only see the red on one side. Tell them to chew on both sides to swish it around. Now, what does the red indicate? So the red indicates areas that the patient missed, okay? The redder it is, the area has been missed more than lighter pink areas, okay? Now, when you explain this to the patient, please don't tell them what a bad job they're doing, okay? Just let them know these are just areas that they need to better focus on, okay? And of course, the red, again, shows them areas that are missed. As you know, if their gums turn deep pink from this, let them know that with the saliva, it'll start wearing away. We're really focusing on the gingival third area and the tooth. So anything past that, even the lip, it will stain. By the way, it'll stain on clothes. It'll stain everywhere. So you just have to be really careful with this disclosing agent. Now, for the maxillary right posterior quadrant, you're going to sit in the 8 to 9 o'clock position, have the patient tilt the head up and turn slightly away from you. Hold the dental mirror in your left hand, use it to retract the cheek or for indirect vision of the more posterior teeth. And you're going to establish a fulcrum on the maxillary right incisors. So here's all this paste, okay? And again, you're going to start from the gums and you're going to step on the rheostat and you're going to do strokes. This tooth probably may use 2 to 3 strokes, smaller teeth 2 to 1. So again, it all depends on the teeth, the size of the teeth. As you're going to the lingual, again, you're staying in the 8 or 9. You're going to have the patient turn the head up and toward you. You're going to hold the dental mirror in your left hand, direct vision in this position, and the mirror provide a view of the distal surfaces. So you always start from the back and you work your way forward, okay, is what they mean. And you're going to establish a fulcrum on the lower incisors and reach up to polish the lingual. Right now, actually, in lab, this is what we are practicing, okay? So sign up for lab on Sign Up Genius right now. And that way you'll get to practice coronal polishing. We're doing perio dressing and sealants. And we are also learning identification of instruments and flossing techniques, fluoride, and also how to pass the instruments. So maxillary anterior teeth on the facial aspect, again, you're still staying in the 8 to 9 o'clock position. Position the patient's head tipped up slightly and facing straight ahead. You're going to make necessary adjustments by turning the patient's head slightly either toward or away from you. Use direct vision in this area. Establish a fulcrum on the incisal edge of the teeth adjacent to the ones being polished. Um, something that has not been mentioned, but you will be also fixing is the light. You want to make sure the light is in the patient's mouth, not in their eyes, not in their chest. That way you have better visual. Um, and also, I don't tell the patient to turn right or left because it is confusing to everybody. So again, just like it's saying here, you either turn towards me or away from me, and it makes life a whole lot easier. Now on the anterior, but on the lingual, again, 8 to 9 o'clock position, and you move to the 11 or 12 o'clock position, again, depending. Position the patient's head, again, so it's tipped slightly upwards, so maxillary is up, lower is down. You're going to use the mouth mirror for indirect vision and to reflect light, and you're going to establish a fulcrum on the incisal edge of the teeth adjacent, and it should look like this, okay? So again, you're using the mouth mirror for indirect. You're going to look in the mirror, okay? You don't want to stress your neck to look underneath here on the lingual side. Here's a fulcrum over here, and here they're retracting. So holding the mirror and retracting at the same time, and over here fulcrum, and the this one, by the way, is the disposable angle. So for the maxillary left posterior quadrant on the buccal, you're going to sit in the 9 o'clock position. You're going to tip the patient's head upward and turn it slightly toward you to improve visibility. Use the mirror again to retract the cheek and for indirect vision. You're going to rest the fulcrum finger on the buccal occlusal surface of the teeth toward the front of the quadrant. Alternative is to rest your fulcrum finger on the lower premolars and reach up to the maxillary posterior teeth. Honestly, once you get in the position of cleaning the teeth, you'll see what works best for you. Maxillary left posterior quadrant on the lingual, again, sit in the 8 to 9 o'clock position. Have the patient turn the head away from you. Use direct vision in this position. Hold the mirror in your left hand and use it for a combination of retraction and reflecting light. Establish a fulcrum on the buccal surfaces of the maxillary left posterior teeth or on the occlusal surfaces of the mandibular left teeth. Your mandibular left posterior quadrant on the buccal side, sit in the 8 to 9 o'clock position. Have the patient turn the head slightly toward you. Use the mirror to retract the cheek and for indirect vision of distal and buccal surfaces. Establish a fulcrum on the incisal surfaces of the mandibular left anterior teeth and reach back to the posterior teeth. And on your mandibular left posterior quadrant, you want to remain in the 9 o'clock position. Have the patient turn the head slightly away from you. For direct vision, use the mirror to retract the tongue and reflect more light to the working area. Establish a fulcrum on the mandibular anterior teeth and reach back to the posterior teeth. So here is a picture on the lingual side. I will do a video or find a video so you guys can watch it of a polishing. Mandibular anterior teeth, facial aspect. You're going to sit either in the 8 to 9 o'clock position or in the 11 to 12 o'clock position. As necessary, instruct the patient to make adjustments in head position by turning either toward or away from you or by tilting the head up or down. Use your left index finger to retract the lower lip. Both direct and indirect vision can be used in this area. Establish a fulcrum on the incisal edges of the teeth adjacent to the ones being polished. The other thing that I see has not been mentioned either is the saliva ejector. The saliva ejector should be in the mouth, and it should be the opposite of where you're working at. So of course, if you're working on the right, it should be on the left. When you go to the left, move it to the right. Okay, and here is of the lowers on the lingual. Notice how their finger here is used as a fulcrum. Now the mandibular right, you're going to still sit in the 8 o'clock position. Okay, have the patient turn the head slightly away from you. Use the mirror to retract tissue and reflect light. So again, what's the mirror used for? By now you should know. Retract. Okay, you're going to retract the cheeks. You might even retract the tongue, or you're going to use it to reflect light. You're going to use it for indirect or mostly indirect vision, and also, again, for retraction. The mirror may also be used to view the distal surfaces in this area. Establish a fulcrum on the lower incisors, and here's what it looks like. Okay, so that's the buccal aspect. So the mandibular right quadrant on the lingual, you're going to remain in the 8 o'clock position. Have the patient turn the head slightly toward you, retract the tongue with the use of the mirror, and establish a fulcrum. That's the other thing. When you're in the lab, you might hear me say fulcrum, fulcrum, where's your fulcrum? Because again, you don't want your wrists and fingers to get tired by not having that stability. Now, flossing after coronal polishing. You can use dental floss and tape. They have two purposes after coronal polishing. The first is to polish the interproximal tooth surface. The second is to remove any abrasive agent or debris that may be lodged in the contact area. You're going to place the abrasive on the contact area between the teeth and work the floss or tape through the contact area using a back and forth motion. So after coronal polishing, I don't rinse. I usually go to flossing, okay? Because if the abrasive is there, you already have it. So the paste, okay, and you can get it in the contacts and floss in between, especially if there's any stains. Then after I finish flossing, then I will rinse the entire mouth, check and make sure I didn't miss any spots. And if I did, I would go back to the coronal polishing only in those areas that I missed. Now, a floss threader can be used to pass the floss under any fixed bridge work to gain access to the abutment teeth. Evaluation of polishing, there is no remaining disclosing agent. So basically what I said, I just double check, make sure I don't see any pink or red. The teeth are glossy and reflect light from the mirror. Also, the patient will tell you too that their teeth are like super smooth. And if they tell you that an area is rough, go over to that area, see why, and polish it again. And even if you're flossing, they'll tell you, I feel something stuck in between my teeth, go to that area and take it out. There's no evidence of trauma to the gingival margins or any other soft tissues in the mouth. So you want to make sure you didn't hurt the patient. Then while you're doing the polishing, you want to give the patient education, because sometimes when it's quiet while you're polishing, it becomes awkward. So talk to your patient while you're cleaning teeth. Most patients too are self-conscious about stains on their teeth and appreciate any tips you can give them on how to keep their teeth as white as possible. It is important to educate patients about the causes of stains. So if you see tobacco, tea, you can let them know that that's what it's coming from. The other thing that you want to let them know too is when you're um, polishing their teeth, you want to educate them about toothbrush. Now, we've had this discussion before about what type of toothbrush the patient should use, soft toothbrush, nylon bristles, using the Bass method. And you need to explain these things to the patients because they don't know. Changing their toothbrush, flossing, when to floss, when to brush, things like that, and even to brush their tongues. Many people do not. So these are things that we need to educate our patients to let them know. When stains are intrinsic, the dentist may want you to discuss possible cosmetic dental care options to satisfy their desire for attractive and stain-free teeth. So the doctor makes the call, then he tells you, give them price, and you will discuss it with the patient. And if they want to do it, then you will schedule an appointment for them to come back to do something on their teeth to get rid of the stains, okay? Also, there might be an alternative to get their teeth whiter, and that's home bleaching. Okay, so again, if the patients ask you, how can I whiten my teeth, then you need to educate them about it. Um, and also letting them know that some food, drink, and tobacco, again, they usually are the ones that cause extrinsic tooth staining. So educate the patient, okay? If they can't let the coffee or the tea or the wine or whatever staining their teeth, the tobacco, go, then they should be brushing more often, okay, to not develop those things. By the way, those nicotine stains, those are like the hardest to remove, because it's like tar on their teeth and it's very sticky and gooey, and when you remove it, it just takes forever. That's usually hygiene also that will do it, and they will complain about those type of cleanings all the time. Does anybody have any questions?